Welcome to part 4 of musculoskeletal disorders. This lecture video addresses scoliosis. You may be familiar with this disorder, or you may remember being checked for it when you were in middle school and high school. But what it is a curvature of the thoracic or lumbar spine. It occurs in adolescence between the ages of 10 to 18. It can be an infantile problem, or it can be juvenile, and juvenile's misspelled, sorry about that. But primarily, we're looking at adolescence. If it occurs congenitally, it is associated with other defects, and it can also occur with other neuromuscular disorders like cerebral palsy, where it's quite common, as well as muscular dystrophy. What we see with scoliosis is a lateral curvature of the spine. It can have one curve or it can have two. If it has one, it is a C curve. If it has two, it is an S curve. So 90% of scoliosis occurs during adolescence. When they get that S curve, it's a compensatory curve to maintain balance when you are ambulatory. When we assess for scoliosis, we have to check the alignment of the neck, shoulders, and hip. They should all be in one straight line. We look at the ribs for a hump on the scapula, and you can see that in both of these pictures. In addition, we look for leg length discrepancy as well as unequal shoulders. And any curvature that is beyond 40 degrees requires treatment. So here is a nice picture of what it looks like, normal versus a scoliosis curve. And you can look at the shoulder. Notice the anatomic difference between that right and left side. You see that nice normal flattening from the neck to the upper arm? Well, that's absent on the left side. You can also see that the hip is a little bit higher on that left side than on the right side. And here's the difference between scoliosis, kyphosis, which is a result of osteoporosis, and lordosis. And here's a nice X-ray picture of thoracic spine involvement or lumbar spine involvement. And this is the clinical exam. And this is exactly what school nurses are doing. They have the kids take their shirt off, and this starts in middle school. So the boys just wear their pants, something loose, so that if we need to really look at the hip and we can't see it that well, they have loose clothing on. Girls wear their bathing suit top, and they just take off their shirt, and of course we examine them in private. So we have this child fold forward. We're looking at the spine itself. Do we notice the curve? Do we notice the hump of the scapula? So when we're looking at the changes of the vertebrae, we're going to see a fixed rotation towards the convex side when they're bending. And so we see that curved hump. So like I said, our assessment begins with the school nurse between 9 and 15 years of age. It should also be a routine part of our physical exam and on hospital admission anytime a child that's late school age into adolescence come in for admission. Children are very good at hiding this disorder from everyone because it leads to a poor self-concept. They don't want to be different. So this is a kid who's going to wear very large, bulky clothes so that nobody notices that their spine is curved. So once again, we're looking for curvature, a hump in the rib, the scapula is more prominent, the shoulders are not even, the hips are not even, they're wearing a skirt, the hemline is going to be lower on one side than the other, or you're going to look at that kid even when they have on these big baggy clothes, and you look at them and say, something just doesn't look right. Have that kid go see their doctor or the nurse. So here's some great pictures of x-rays. Look at that degree of flexion. We brace curves that are between 20 to 40 degrees. Anything that's a little bit less than 20 degrees, we use the wait and watch approach. That's mild case, but that child needs to be re-examined in 6 months. What the brace does is it doesn't correct the disorder. If we can keep it between 20 to 40 degrees, then that kid is going to be okay in their lifetime. So what the brace does is it prevents increasing the curvature of the spine. And if it increases the curvature, then they need more drastic intervention. So this is where our job is really difficult, because you need to convince the patient as well as the family that this brace needs to be worn 23 hours a day, and they're going to wear it for 1 to 2 years. And I have some pictures of what it looks like, and you can see why these kids are going to be reluctant. We still want these kids to be active. They need to be careful. They need to use handrails so that they don't fall, because their center of gravity and their ability to fall is not going to be as flexible if they didn't have this brace on. And they should avoid heavy loads like that backpack that they carry, because that puts more traction on the spine. We need to teach them to protect and assess their skin for areas of breakdown. Most of the times these kids will be able to feel if it's too tight and it's rubbing. They still need to go to school. Wearing a brace is no reason not to go. We want to support their self-concept. They can still go to the school dances. Orthopedics will allow them to go to a dance even without the brace. If it's off for just a couple of hours for one day, that's not going to completely defeat the treatment. So they can go to the prom and the winter formal, but it goes right back on as soon as they come home. Reinforce compliance with this brace. Here's what it looks like. And if they have a higher curvature, this brace can go all the way up to the neckline. Those kids are very reluctant to wear it. So here's a child being fitted for the brace. She's not a happy camper about it, but she would be less of a happy camper if she needed surgical intervention. And you can see how this child did very well in continually growing in the spine and not increasing the curve. Now, if they do not respond to a brace, then they're going to need surgical correction. They don't want to do it immediately because this child is still going to grow. We'll do it earlier on kids with special needs who are on constant bed rest because they're never going to respond to bracing. So what we do when we do surgery is they actually put in rods and they fuse the bone. And you can see what this looks like. I like to show these pictures so that when you're taking care of these kids post-op, you realize why they have pain. And they are cut all the way down the spine when they have the surgery. So preoperatively, you need to teach them that they will be on monitors. They're going to have a Foley catheter. They're going to have an IV. They're going to need to use a bedpan. They're going to have pain, and we'll teach them how to use that PCA before surgery, and then provide the psychosocial support. Postoperatively, you need to do frequent assessments. Look at the dressing, do your CMS exam, monitor their blood pressure, and assess for pain. Some of them may need to get an autologous blood transfusion. Some of them may be fluid depleted, and they're going to need a fluid bolus, so watch their urine output. Once again, we're going to administer pain medication via a PCA. When you turn this patient, you have to use the log roll technique. Use a bath sheet, get some help, and you are going to roll the patient completely over in one movement from head to toe. These children must use the incentive spirometer at least 10 times each hour while awake, and then monitor for skin breakdown. Eventually, they will be fitted for a supportive brace, and they're going to wear this brace for 3 to 6 months. Here's some pictures of what the curve looked like beforehand and what it looks like afterwards with the Harrington rod insertion. Looks pretty good, but can you see why they're going to have pain? This child only needed to have one rod. And this ends the lecture on scoliosis.